So, we're going to talk about a lot of very common myths with respect to reimbursement and market access in the medical device world. I have been doing this for a long time. I've been working as a health economist for 20-something years. I hate to say that out loud. So I've kind of seen it all. And I picked I think I have 16 myths or something, sort of picked my 16 favorites. There's lots of them out there. And then I also have case studies that we're going to talk through as well to kind of highlight, how you overcome these myths. But really, there are lots of myths out there. You will likely, when I put them up one by one, you will likely have either fallen prey to the myth in the past, know someone who has fallen prey to the myth in the past, heard someone talk about it before, tried to advise them away from that line of thinking, something like that. Some of them are a little bit tricky. Some of them seem very common sense, like this should be true, and it's not. And those are the ones that we'll want to focus on, the ones that kind of can really lead you into that trap. But if you fall prey to one of these myths or one of these pitfalls, it really can cause you problems. It can lead to market failure. For a startup, it can really be the death of the startup if you fall prey to some of these myths. At the very least, it can set you back years and lots of dollars. So what we want to do is really focus on dispelling these myths, talk through what's important to execute a systematic reimbursement and market access strategy. How do you develop, prove, and articulate your value proposition? All three of those steps are really important. And how do you collect the right data, be the right clinical studies? So we're going to touch on all of those things, but we're going to just start out. I'm going to go through myth after myth after myth. Now, as you will probably figure out, I can talk a lot. Given the opportunity, I will talk a lot. I don't want to talk a lot. I like to be interrupted. So if at any point you have questions, please just raise your hand. I'm happy to answer questions as we go through. I know I spent a little bit of time going through the introductions, but it's really helpful for me to hear where you're coming from, because then I can tailor some of what I'm saying to some of your specific positions. It truly is getting hot up here now. Mm-hmm. It's very hot at this point. So now I'm going to walk over and get the water. I've dropped the coffee, now I'm going for the water. But this first myth, this is what I was faced with just about every day when I first started Decision Driver back in 2006. And it's less pervasive now, but it was very pervasive then. I used to refer to my clients who would come to me thinking this as the train wreck clients. They thought their primary hurdle was just getting FDA approval in the US. So everything they did was geared towards FDA approval. And many of them had not given a thought to what the payer system meant. They had not just given one moment of concern to that. And so what they would find is they would clear that FDA hurdle and then find, I would say, either they crash into the brick wall that is the payer system, or they would find that there's an even higher hurdle that's widespread coverage or widespread adoption. And so I heard someone from CMS, the Centers for Medicare and Medicaid Services, years ago at a conference say, the FDA gives you permission to market your technology, to sell your technology, but FDA approval doesn't give me a single reason why I should buy it. And so that's the piece that you have to remember. What the payers are looking for is very different from what the FDA is looking for. And if you don't know that, you can get your FDA approval and think, I'm done. Now all I have to do is go out and sell this and money's going to start coming in. It doesn't work that way. Okay. Related. A lot of these you'll find are related, but it's a little bit of a nuance. So myth 2, FDA clearance means your technology is no longer considered investigational, experimental, not medically necessary. Now from the FDA's perspective, they're saying, okay, you've shown me that you're safe enough and you're efficacious enough to be used in the marketplace. Again, from the payer perspective or from the provider or facility perspective, it doesn't really mean anything. From their perspective, when you first enter the marketplace, unless you have a lot of clinical data, and typically longer term clinical data, they will still consider you to be experimental, investigational, and not medically necessary. And that's really important to understand. I had a client a couple of years ago who, and they've been on the market for a while. I mean, for several years, they were kind of fighting that reimbursement battle that I'm sure many of you are aware of, kind of case-by-case coverage of their procedure. And they went into a meeting with the payer, and the payer said to them, well, you're experimental and investigational, we're not going to cover this. And they were just astounded, but we have FDA approval. It was like they were just jumping up and down, but we have FDA approval. Like, we don't care. You're still experimental and investigational. Again, that's important to understand. Okay. This is a big one, okay? Our technology doesn't cost very much. Our technology costs less than what's currently available. So the payers are going to say, fantastic. We're going to adopt this. It costs less than what we're currently doing. We're good. Does anybody think it really works that way? It doesn't really work that way. And so here's the reason, or one of the reasons why. Oh, I should also point out that the little asterisk at the end, if it has an asterisk, it means I've got a case study that's specifically going to address that point in a little more detail. But it's not true. So for example, maybe you have a minimally invasive procedure that costs less than the current standard of care, very invasive surgical procedure, but it's not curative. So big invasive surgical procedure cures whatever the problem is. Your procedure helps, but it's not really a cure. Yours is a lot less expensive, patients like it better, seems like it's a good deal. The payer looks at it as, okay, but it doesn't cure it. So is this something that's going to have to be repeated in a year, in 2 years, every 6 months? Or is it something that I'm going to pay for twice, and then they're going to go to the definitive treatment in the end anyway? So they're looking at it as, over a longer run, a more expensive option for them, rather than a less expensive option. So your time frame is really important to think about.
Guy, can I ask a question on that?
Of course.
At what time window do you find the payers are commonly looking at it? 3, 4, 5, 6 years?
You know, typically, they'll say they want to look at lifetime costs if it's a chronic disease. Not really so much unless it's Medicare, because they really are concerned they're going to be taking care of that patient from 65 on, however long that patient lives. Private payers, a 2 to 3 year window is what they're most concerned with, typically, because that's about how frequently patients jump plans. Yeah. So they want to understand that 2 to 3 year window, typically. You can show them longer, but they will also want to look at kind of that slice of it as well. But anything shorter than that, they're worried. They're worried that they're going to end up paying more. So if you say, well, we have great 6-month data from our FDA studies, well, that's not going to be long enough for them. So you want to think about that when you're designing your studies. Okay. So related to that, clinical data from the FDA equals sufficient data for payer coverage and payment. Again, absolutely not true. You can put a checklist side by side of what the FDA is looking for and what payers are looking for, and there's hardly anything in those two lists that match up. So the FDA wants short-term safety, and they want short-term efficacy. So efficacy means that it works, it can work in just the right patient population. So you've demonstrated that if you pick just the right patient population, you use it just the right way, then it works. What the payers want is they want safety, but they want short-term and long-term safety, and they want effectiveness, short-term and long-term. So what's the difference between efficacy and effectiveness? Anybody?
Well, efficacy is it works, but effectiveness is long-term. You're going to have to repeat it multiple times, or you're going to have to, is it a stopgap, and then you're going to have to do a more expensive or alternate procedure in order to actually treat the pathology.
Right. So I usually think about it as efficacy is, it can work under exactly the right conditions in a short period of time, and effectiveness is it does work in a broader range of patients over a longer period of time. So if you think about, a technology that enters the marketplace and you've done your clinical studies, you've picked exactly the right patients for that procedure. You've picked patients who they don't have too many comorbidities, they're not too old, they're not too overweight, they don't have too much other stuff going on that's going to confound your results, and that's where you study your efficacy and your safety for the FDA. That's not what the payers are interested in, because payers know this gets into the hand of physicians with all kinds of messy patients and all kinds of different situations. They decide to use it in very different ways in patients who don't fall into those parameters, and they want to understand, is it effective? Does it work in those kind of messier situations and over a longer term? So that's one thing that's very different from what the FDA wants versus what payers want. FDA also cares about, your study can be very tightly designed, very tightly controlled, a very protocol-driven scenario. Payers want to know what happens when this gets turned loose with all kinds of physicians who are going to use it all kinds of different ways. Again, these broader patient populations. What happens when they're doing other stuff to these patients? What happens during the follow-up period? So they really want to know actual use, what's happening, compared to what they're already doing. They don't care about your technology versus a placebo because they're not giving placebos. They're paying for something else, typically, if there's a competing treatment. They want to know how it works compared to that. So there's lots of differences there about what they're looking for that's very, very different. Okay, so this is one of my favorites. I've heard this one so many times, and it is such a bad idea. Such a bad idea. Immediately after we get FDA approval, we're going to go for formal coverage determinations. We're going to go straight to Medicare, and we're going to demand that they cover us and make a national coverage decision. Or we're going to go straight to United Healthcare and Blue Cross Blue Shield, and we're going to demand that they make a formal coverage decision about this technology right as soon as we get FDA approval, because that's going to make it easier for us. Then we're going to go out, and we know that any physician who wants to use this technology is going to be able to use it. And it does not happen. 99.99% of the time, if you do that, they will make a national coverage decision, and guess what it's going to be? It's going to be a national non-coverage decision. So they'll make the national decision. They're very happy to do it, as a matter of fact. I like to say that payers have a big no stamp. They have it right in their desk drawer. And they really like to pull it out. They like to say no. Because saying yes is scary, right? They say yes, all kinds of things can happen. So they like to say no. And if you come to them with a brand new technology that's unproven in the marketplace and say, we want a national coverage decision, they'll say, fantastic, here it is. National non-coverage decision. So what has that done to you? That means that any physician who puts your CPT code on their bill and sends it into the payer, they look it up on their list and it says not covered, period. Not covered. There's no appeal, there's no process, you're just not covered. Versus if you go out into the marketplace and you don't have any kind of coverage decision, you can win those on a case-by-case basis. It might be a little bit painful because you have to go through that process. You have to, you might expect to get rejected the first time, but you can appeal it and you can win on a case-by-case basis, but it's not a blanket no automatically. So this is one that is really, really dangerous because it kind of seems like a good idea, but it's not, because you'll almost never have the data that they're going to want at launch to make a favorable coverage decision. Okay, here's one that's going to be relevant to several of you in the room. So for some of you, Blue Cross Blue Shield, Medicare, United Healthcare, the third-party payers are not relevant to your technology. You're a technology that you're going to sell directly to a hospital, that they're going to utilize within their hospital, within their procedures. They're going to be reimbursed under a DRG or under a case rate or something, and your technology is something they pay for that the payer never sees. So maybe it's some sort of a technology that's used during open heart surgery that will help reduce complications during that surgery. So the facility is going to get paid for the open heart surgery, and whatever specific supplies and technologies they use during that procedure, they're responsible for. They're going to get paid so they can decide specifically what to use. And so your customer is the hospital. It used to be that this was true, that if you didn't have to convince the payer, that the hospital was an easier sell. But that's not true anymore. Does anybody know why that's not true so much anymore? What's changed?
Liability.
There's a little bit of liability, but there's also a completely different process within hospitals. It used to be that all you had to do was convince the physician or the surgeon that they wanted your technology. And the surgeon kind of reigned supreme and could go and say, I want this. And the hospital would say, okay, you're our surgeon and we want to make you happy, and it doesn't work that way anymore. There's things called value analysis committees that live inside pretty much every hospital now. Most hospitals have more than one of them. You might have a value analysis committee for things that are going to be used in the ICU. You might have a value analysis committee for things that are used in the emergency department. You might have a cardiovascular cath lab value analysis committee. Ortho value analysis committee, absolutely. Where they're looking at clinical evidence, they're looking at economic implications, they're looking at all of it. So they have a group of people, physicians are part of that, but you have physicians and purchasers. You can have even janitors as a part of that. One of the craziest stories I ever heard was of a janitor who was a part of a value analysis committee actually being the one to reject a technology because of the implications that that technology would have had on cleanup between surgical procedures. So there's it's a multidisciplinary, multifaceted process now that happens at hospitals. It's not enough just to get the surgeon. It's not enough just to get the physician. You really have to have that whole value proposition. You have to show safety, you have to show effectiveness, you have to show, now we'll talk about the triple aim of healthcare, and with one of the case studies later, you really have to show broader implications to a broader group of people. So this is really not so true anymore.
Do they also have a nose stand?
They have a nose stand. They do. It's not quite as large, but it's large. Yeah.
I have a question.
Yes.
With even this being kind of a myth, is there a way to use doctors and different KOLs to
Absolutely.
take it to the back?
Absolutely. That's a great question. So if you can find a clinical champion within the hospital, so if it's one of the surgeons, you can arm that clinical champion with the information they need to make a better case. So they can come in and not just say, I want this, but I want this, and here are the implications it has on the hospital's, population health, on the patient experience and care, on overall costs. So you can arm that person, and that person can take that to the value analysis committee. So they can, yes, you can still work through that way. It's just a broader bit of information that needs to be presented. Yes?
What about directly to the doctors, where you're not dealing through a facility?
So if you're dealing directly with a physician office, it can be somewhat easier, but you're still going to have that broader position because they're also a business. And so you're going to have to make the business case to them as to why it works, based on how they would be reimbursed. Is this a technology that they would purchase and
what
that they
if
would
they're
reimburse
not
separately?
trying to get reimbursed?
If they're not trying to get reimbursed.
They just want the product.
If they just want the product, you still probably have to make somewhat of a business case for them.
Okay.
If they're going to be buying it and nobody else is going to be buying it back from them, you'd have to make a business case with them. But it can be a little bit easier in that circumstance.
What are the products usually that would get easier market access? What are some of the factors that some products could be market?
Okay, so the things that can...
Well, not approved, because I'm not interested so much in that.
Right, but from a market access perspective. So let's suppose, and we're not talking specifically about coding too much, but some of you probably are aware of CPT codes and some of those issues. So let's suppose you have kind of a Me Too type of technology. Me Too, but a little bit better, okay? Me Too, but a little bit better. It has a CPT code. That CPT code has favorable coverage so that it's not being rejected by the payer. So it already has, that CPT code already has widespread coverage. The payment on that CPT code is adequate for you. So your technology, it's okay. You're not spending so much making your technology that the payment's inadequate, because that can be a problem. But if you have that situation, there is a code that fits, it's covered, the payment's adequate, then you can just slide right in. So that's about the easiest case that you can have. Sort of the pitfalls with that, and we'll talk about it in a second a little bit more, is being trapped thinking having a code is all that it takes. Because that's not true. But that specific scenario, you have a code, there's good coverage of the code, and the payment's adequate for you. That's about the easiest scenario you're going to get. Yes?
Going back to that last question, that last myth, is it not true that every department has its own budget these days, or?
Well, it is, and it sort of depends on who you're selling to and how the hospital works. And this is one reason that, when you're selling directly to a hospital, if you're a larger company who's selling to a hospital, you have a good team of sales reps out there. it's very important for them to know those hospitals and to know how they work and how to navigate them. When you're in a situation where you're a true startup and you probably don't have, that kind of a sales force, what you should do is, identify hospitals that have probably worked with you to help develop the technology, maybe in some of your clinical studies, start accessing from there, because an understanding of the hospital and how they work and how their value analysis process works is really important to making sure that you're presenting the product in the right way. So it can, people ask me all the time, you might have heard the term backpack. Has anybody heard that before? So they'll say, well, what do I need in my backpack? Well, Google backpacks, by the way. It's really interesting what comes up, because I did that one time. It was lots of vacuum cleaner stuff. But also you will get actual backpacks from medical device companies. But typically there's lots of good things that can go in a value analysis committee package that includes all your clinical safety and effectiveness information, all your data, maybe statements from societies about why the technology is good and why they support it, budgetary impact models, lots of reimbursement information, whatever's available, lots of different things that can go in there. But typically, for each hospital or different type of hospital you go into, you kind of want to pick and choose from those things, what's going to be most compelling to them.
I have a question on that.
We'll go here and then here.
So once you have a mid-sized hospital approve and use the product, how would you just roll it out to the rest of the world?
The masses?
Yeah, the masses. So step one's done, how would you do that?
Yeah, so, you can, I wish that I could tell you that if you just got adopted by Duke University, that every other academic institution would just roll right on board after that. That's not the case, but it doesn't mean that you can't use case studies. So it is helpful once you get those first couple in different groups. So if you get an academic institution that adopts the technology, and then you get a community hospital that adopts the technology, and you get, you can use that and say, this is being used now at XYZ hospital, they're very much like you, here's how they're similar, here's the evidence that we showed them, so on and so forth, and it's helpful. Unfortunately, they still all will go through their independent evaluation process, so it doesn't short-circuit it too much or shortcut it too much, but it is helpful.
To answer your question, I found that getting into an integrated delivery network and having one hospital and pilot the crap out of that hospital and then socialize that within the integrated delivery network, the path to adoption is much, much faster if it's within an IDN. So pick any hospital, doesn't matter which one, pilot it, be successful, and then commercialize and socialize that success inside of the IDN. Much faster path than hopping from one administrative organization.
What's an IDN?
An integrated delivery network.
What is that?
Partners, Kaiser, HCA.
Yeah, it's a whole system. So Kaiser is sort of a prototypical example where they own the hospitals, they own the physician offices, they're paying for everything, medications, everything. So
when you're launching a product, they all are big to you, right? So you can take any of the top 10, they're all huge. Just get into one and socialize that, and you'll cut down half of the effort if you're successful.
Some advice.
I want to ask a question off of something you said. You said best case scenarios, if a code is already there, it's reimbursed already. Let's say that's the case, and your technology is going under that code. How much scrutiny are you going to get if the code is fairly broad and you're slightly different technology than what's being used, but it could slide under a particular code? Is that scrutiny still going to be fairly strict from a payer perspective?
It can be,
Yeah.
so let's say, we'll talk about this a little bit more, but so I said one of the easiest cases is when you have a code and there's good coverage and there's adequate payment for you. But it's not the only good scenario. Sometimes building your own code is a great thing to do. It might take a little longer, but it might be best for you financially in the long term. Plus necessary. If you need a new code, you need a new code. But there are scenarios where, let's say it was a CPT code that exists. Like you said, maybe it's broad. Maybe it's not used that much. And so it's got favorable coverage, but payers really don't see it that frequently. All of a sudden, you have a technology that physicians really like. They start seeing that code all the time. So it sort of gets on their radar. They can go back and revisit it at that point. They may go back and look, okay, wait a minute, now this code's being used in this way, this is a new technology. They may decide they want to track your particular technology, the way it's being used under that code. So one of the things that we always caution you about, and we're going to talk about it a little bit later, is how aggressively you're marketing your brand new technology. While you're investors and you would love to see millions and millions of dollars within the first couple of months, payers will be alarmed by that. And so there's a little bit of flying under the radar until you have some more experience and more data that's a good idea. So that might be the scenario that you're describing.
Sorry, to piggyback at the top of that, I know there's a lot of questions. To piggyback off of him, is there any such thing as a market share of a code? So, I don't know, let's say there's code 7000, Medtronic and Stryker want to see who has the greatest market share, so they look at that code.
For the most part, they can't track that unless the payers, there's something, and I'm not the reimbursement director in our organization, so I can get myself in trouble really fast. So don't anybody tell Julie that I'm talking about this at all. They can, if they start to be concerned that there's one particular technology that's driving this code, they can assign an identifier code to that specific technology so that they can identify which code is associated or which technology is associated with that code when it's billed. It doesn't happen very often. Usually they're just seeing the code and they don't have any awareness of what the technology is. But if they start to see this overutilization from their perspective, they can start to investigate and say, oh, I want to know what's happening with this specific technology, and they can assign kind of a subcode to it so that they can track it.
Got it, thank you.
Mm-hmm. So this is another one that I think is a pretty common one. Nobody knows our technology's value story as well as or better than we do. It's our technology, okay? One of the reasons I love working with medical device companies is because everybody is really passionate about their technology. And I love that. I really love that. Sometimes it's warranted, and I get just as excited about their technology. Sometimes I'm like, I'm not seeing it, guys. I'm not so sure that that's such a great idea. But you can be so trapped by your excitement for your technology that you don't really see how the rest of the world might view it. And it's really important to get that view. We're going to talk about qualitative research a little bit in one of the case studies, so I'm going to leave it there for now, but let's come back to that in a bit. Okay? RCTs, randomized clinical trials, are the only studies that payers will consider when making coverage decisions. Okay? Does anybody think that's true? A lot of people typically do, because again, the payer has the no stamp. So when you come to them with your FDA data, that very often is just case series, it's just your technology and there's no comparator, they will give you the no stamp, and what are they going to tell you? They're going to tell you why. We want to see RCTs. So they'll say that to you, but it's not all that they'll accept. There are creative ways around this where you can present them with data from other studies, different study designs that will be acceptable. We'll talk about that in the case study too. Okay? We're a startup. I can't afford to do this. Okay? I hear this one all the time. So again, startup, a lot of you are in that situation. You have just gotten through your Series A, your Series B rounds. You've got just enough money to conduct the minimal study that the FDA wants you to conduct. And when I come to them and say, but you need longer term data, you need to think about these health economics endpoints, you need to think about the patient perspective, you need to do, they're like, I can't do that. I don't have enough money to do that. It's absolutely no. I just need to get FDA approval, and no. So what happens to them when they do that?
You run into a wall.
They run into the wall. So they conduct the minimal study, they get that data, they get FDA approval. The payers look at that data and say, that's not what I want to see. And now they're at the brick wall. So what are they going to have to do at that point? Do another study. Does that cost more or less than doing it the first time? More. So it's something that we really, you really have to think about. Yes, it's going to cost you a little bit more to add some additional endpoints to your FDA study. It's going to cost a little bit more to extend the data collection time frame. But is it going to cost you as much more as conducting an entirely different study once you hit the brick wall? No, it doesn't. And there are creative ways, again, that you can get at some meaningful data.
So when you're doing that and you have and you're collecting that data as a startup, it seems to me that if your goal is to be acquired and after FDA approval and whatnot, it seems that having that data from the first time around is actually going to improve the valuation of your company anyway,
Yes,
right?
it will.
So doing that work up front is, even if your goal is to be acquired after FDA approval, it's still in their
It
best
still
interest
helps
to do
you.
it.
Yes, absolutely. And that's a great example. Thank you for bringing that up. Because because again, I do have clients who are like, well, I don't want to market this product. I just want to be acquired by Medtronic. Okay, that's a very valid goal that lots of companies have. I want to be acquired by St. Jude. I want to be acquired by Boston Scientific. I want to be acquired by Medtronic. And so I don't, I'm just going to get the minimal amount done. Well, we're actually working with a company right now that's being evaluated by Medtronic. And one of the things that Medtronic is really finding valuable is that we have been conducting economic studies with them. So they have an idea of the economic implications of this technology versus the standard of care procedures, and their valuation is increasing. So that's a great point, yeah. Yes.
So I know we're talking mostly about sort of US side kind of data gathering and approvals. But is it possible to generate sort of the usual path, tread the European boards first and bring some data back? By the time you're cleared in Europe, now you're free to use, quote unquote. All the other barriers have fallen away. You've now got an available population that you can now leverage for maybe randomized clinical trials, but certainly the foundational aspects for value add and long-term follow-up without hamstringing your US side clinical studies. Is that a viable strategy?
It can absolutely be a viable strategy if you're in that scenario. And again, we do, a lot of the companies we work with, they're just going for the US first, and they don't have any data from Europe or from Australia or from Asia or the rest of the world. But if you do, you can very often leverage some of that data. It just depends, though, on basically the treatment protocol. So in some situations, the treatment paradigm is different in the US than it is in some of the European countries. And if the treatment paradigm is different, and the way your technology is being utilized in that treatment paradigm is different than it is in the US, then you can't leverage it as much. But if it's very similar, then you can leverage that data. You will find that payers really like US data, but you can help them overcome some of those initial gaps with some data from the rest of the world if the situation is right in terms of the treatment. Okay, I think I haven't talked about this one yet, have I?
No.
I think I switched it while you guys were talking. Okay, so investigator-initiated or sponsored studies are great data for market access. And I have a lot of clients who come like this because, I don't have to pay for the whole clinical study. I've got Harvard wants to conduct this study for us, and so that's great, right? That's like the best case scenario because it's Harvard, and they're generating our data and I'm not having to pay for it. And it really sounds great, and sometimes it can be great, but sometimes it can be disastrous as well. Because if they're initiating it and they're sponsoring it, they have control over the data. They have control over how long it takes them to publish. They have control over what they publish. They have control over what the comparator is. They have control over the study design. It can end up making your technology not look good when, if you had taken a little bit more control over it, it would have been a different scenario. And so it can go wrong. Typically it doesn't go wrong in that way. It goes wrong in, if you sponsor the study, you might get your study done in a year. But Harvard, well, they're not really concerned about your timeline. It doesn't matter to them how quickly this data comes out. So their data comes out 3 years later. That's a big deal. 1 year versus 3 years to have this data. So it's just something to think about, but it's not always the best route. And usually there's some sort of a middle ground that you can find there. Okay, this is another one of my favorites. And we have a case study where we're going to talk about this. So I'm not going to go into too much depth, but everybody wants their market to be as big as it possibly can be. Because you want to tell your investors, we have a treatment for obesity. Think about what a huge problem obesity is and how many millions of patients that affects. Or we have a product for type 2 diabetes. It's a growing problem. You want your investors to see a big problem. You don't really want your payers to look at your technology like that. And we'll talk about that more with a case study. Okay, this is another one of my favorites. So I like to do complicated stuff. I'm a mathematician, remember? I'm weird. I like to do crazy complicated stuff. I don't do crazy complicated stuff very often because you shouldn't unless you need to. If you have a simple, straightforward story that generates your value proposition that you can prove, tell a simple, straightforward story. It will always be received better. It will be believed. If you have an analysis that's so complicated that nobody can understand it except a health economist or a mathematician, and you're trying to show this to a medical director of a payer or to a hospital, first of all, they don't even want to look at it. It's kind of scary. Secondly, they tend to think you're trying to hide something in all the complexity. You know, they tend to think that, well, if you threw in everything but the kitchen sink, it must be that you don't have any story unless you throw in everything but the kitchen sink. So it can go wrong. So simple is better when you have simple. Sometimes you have to make a more complex story, but if you don't have to, you shouldn't. Okay, this is another one that a lot of people tend to think, that your technology will be paid based on its value to the healthcare system. So I've had lots of clients over the years come to us and say, my technology is going to save payers millions of dollars a year. So they're going to pay a premium for that. That's not how it works. They don't pay based on what you're saving them, even if you are saving them millions of dollars a year. That's not how it works. They pay you based on the coding structure that you fall into, and the coding structure that you fall into is based on, you can build your payment structure to a certain degree based on the price of your technology if you're building a new code, but it's mostly based on the resources that go into executing the procedure. So if you have a technology that takes 2 minutes of a physician's time and 10 minutes of a nurse's time, those time estimates go into how much that procedure is going to be paid. It's not based on that 2 minutes of the physician time and 10 minutes of the nurse's time that saves millions of dollars, so they're going to pay you $3,000 for that time. It doesn't work like that. That's not how those codes are valued.
How do they look at technologies that may cost more but increase quality of life or extend life? How is that evaluated?
So the standard in terms of a payer perspective and cost effectiveness analysis is they will pay more to extend life or to extend quality of life. So they look at how much more are they willing to pay to get an additional unit of that effectiveness. So typically you'll hear they'll pay $50,000 per quality adjusted life year gained is sort of the standard metric, which if you've never heard that before, it sounds a little bit crazy. So again, this one we've talked about a little bit already. We're in great, we have a CPT code, we're all good. I hear this one all the time too. And sometimes I'll say, yep, you've got a CPT code, but that CPT code has a national non-coverage decision associated with it. So that's really bad. So you fit right into that code and it's not covered. That's a problem. So now you would have to generate the evidence to overthrow the non-coverage, which is a whole big problem to have. The other situation is there's a CPT code that exists, you fit in it, it's covered, but the payment's not adequate to support your technology. That's also bad. You know, the code pays $500, you're planning to charge $2,000 or want to charge $2,000, but that's not going to work. And then there's nothing you can do about it. So it's not that easy as just having a code. Okay, I finally get to the positive one. The last one is positive. Today's reimbursement environment is tougher than ever. So I don't think that's true. I don't think that's true. And the reason that that's not true is because the reimbursement environment, and we haven't really talked about this yet, but we will as we go through some of the case studies, we're kind of evolving a new reimbursement paradigm. So it's not just fee-for-service anymore. It's not just the procedure you do gets paid. And so the more physicians perform this procedure, the more they get paid, and the payers look at it that way. Value-based reimbursement is really coming into play, bundling of care, so that payers are entering into arrangements with hospitals or with integrated delivery networks to say, okay, I'm going to give you this amount of money to manage a diabetes patient. So you're looking at a much more comprehensive view where you have more opportunities to show cost savings in different areas and create a value argument for the payer or for the facility. So there's a couple of different avenues. You've still got fee-for-service, but you also have the value-based reimbursement. There's different ways you can get at creating an argument. There are also more payers who, you know, again, if you're going into an area where they have a high prevalence of a condition like asthma, for example, and we're going to do a case study about asthma in a second, where they know that asthma patients cost them a lot of money. A lot of payers have disease management programs to help, you know, control healthcare costs and patient management in those populations. If you have something that can be utilized, that you can show how it can lower their overall cost of care in a very specific population, they'll trial it within their disease management program. And I'll go through a specific example in a minute. But there are situations like that, and in trialing it, they're generating data for you. So they're helping you in lots of different ways. They're using your technology, but they can also be generating data for you. So, you know, identifying those kinds of opportunities can be really important. And they exist more now than they used to.
Have any of your clients focused only on accountable care organizations and capitated payment plans and avoided fee-for-service?
I haven't had any that only do that, but I have some that really, you know, focus most of their efforts.
Both camps,
you do.
Right? That's double the consulting work for you.
It is. It's great. But it really is important because, you know, in any hospital that you go to currently, they have, you know, this is one thing when I have clients who come from ex-US and coming into the US. I have several Australian clients or European clients, and they say, I want to understand US reimbursement. And I always say, well, fasten your seatbelt, because none of us really understand US reimbursement. And it's really weird. I mean, it really, the rest of the world's reimbursement makes more sense than our reimbursement. Ours is extremely complicated. And it's because we have all these private payers. You know, there's not a single national payer where it makes more sense. So any given hospital has hundreds and hundreds and hundreds of contracts with private payers. Some of them are all fee-for-service. Some of them are part of a value-based bundle. Some of their patients are under the value-based. So it's incredibly complicated. You have to have arguments for all of those different scenarios that can fit together, and that's what makes it so complicated. Okay. Any other questions before we kind of run through some case studies?
So you were talking a bit right there about the value-based versus fee-for-service, and I know like Medtronic, for instance, has been making at least advertising that they're doing more of that you don't pay for it if it doesn't work model. Do you see more of it moving in that direction, or is this more just kind of an isolated advertising campaign?
It's still reasonably isolated, but I'm starting to see my clients get asked more. So think about a facility's perspective that's had Medtronic come in, and Medtronic says, hey, we guarantee that this is going to work, and we guarantee that it's going to lower costs, or you don't have to pay for it, we're going to give you this money back. So you think about a hospital who's had that experience, now that hospital asks everybody else who comes in if they're going to do the same thing. So it's still pretty low level at this point, but a lot more of my clients are coming back and saying they're getting asked that. Not that they're getting rejected completely if they're not going to do that, but they're getting asked. And I think in time, you're going to see that start to increase, because most of the hospitals now are also very frequently saying, okay, we're going to adopt your technology, you know, for this specific patient population or these specific scenarios for a year, and we're going to track how it does. And so they're not requiring at this point to the manufacturer to give money back. But if they're not showing the cost savings that they've been promised or told they would get, then they're not going to continue using the technology. That I'm seeing a lot of. They came to us saying, we want to conduct a big study, a really big study, to confirm this. You know, they wanted to, immediately go out and enroll like 100 different ophthalmology centers, conduct this big comparative study to demonstrate this very particular benefit. And we said, well, before we spend that much money, let's just make sure that we think that value proposition is really there. Let's go out and talk to, I forget how many we talked to, like 10 or 12, and just, talk to them about, first of all, is this their experience? Is this really causing them a problem? Is it really costing them money? The fact that patients are non-compliant with their, or your supposition that the patients are really non-compliant and that causes problems for them before we implement this really big expensive study. So they agreed that, okay, we could do this, this qualitative study. And we went out and interviewed, these 10 to 12 different sites. And what we found was they're like, no, that's not a problem. That's not a problem for us at all. No, we don't have anybody coming back because, and even if they don't use it, it doesn't really cause problems with their outcomes. We don't see them. And I mean, it just blew their whole value proposition out of the water. It did identify another problem, though. The problem, they said, was with the prescription process. They said that we do have a problem with writing a prescription because the generics don't work as well as the brand eye drops. But the payers don't want to pay for the brand, and so they substitute the generic, and then we have to go through this whole process, and we have to call the payer, and we have to do this. That causes us a problem. So we identified a story that they could tell that was related to something their technology could help. But if we had gone after the other story first, we would have totally missed it, and they would have spent several $1 million going the wrong way, and it wouldn't have proven anything. So really important to understand, you might know your value proposition, but you might not. Don't go whole hog after what you think your value proposition is without having some objective research to confirm that. Because one of the things that we found is many of our clients will say, well, we've asked all those questions, and yes, they've said that this is a problem. And it might be, well, it might be how you ask the question. It might be you can lead with your question. It can be, don't you agree that this would be a problem? And then, yeah, versus, just framing it in a different way. Saying, well, what do you experience after a patient has cataract surgery? What is your experience where you're not leading them down a path? And so that's an important thing to understand. Yes?
So a slightly naive and tangential question. Do they have any data that shows that the generic doesn't work as well as original? And if so, why isn't that a bigger problem in general?
Well, it actually is a bigger problem than you would expect that it is, because with generics, they have to show bioequivalence. And for the most part, now I'm totally getting tangential, but that's fine. It's bioequivalent, but it doesn't necessarily mean that it's as efficacious. And so there are specific circumstances where they're not. There's a couple of blood pressure drugs that are known for that, where the generics are known to not work as well as the brand. There's a couple of other indications. It doesn't happen that often, but there are a few where over time you'll see that there is evidence that shows that one is not as effective as the other, but it tends to be more anecdotal.
Right.
So you will hear, and this was something that was very interesting to us because we had not expected it at all in this circumstance. We went and talked to these 10 different facilities, 10 different ophthalmology groups. We had no preconceived notion about that at all. And all of them said it was a problem, which I think anecdotally points to there probably is an issue with some of the generic eye drops, at least with certain of them. There's usually multiple generics in that situation. But it was really fascinating to us to see that. We never expected that kind of issue would come up. But they would point out they have to be shaken more aggressively in order to work, like the mixing with them, and so they said if they don't shake them as aggressively, then they don't work as well, versus the brand. If you can just shake it a little bit and it works. I mean, it was just stuff like that can crop up with the generic versus a brand. Oh, but just on this, the client's value story upended. This was an interesting phone call to be on. So this was presentation of results that occurred. I like to do that in person when I can, but a lot of times it's over the phone. And this was, you present the findings of your research, and it was completely counter to what they expected. There was dead, utter silence on the other end. They had their whole executive team we kept saying, are you still there? It just blew their minds. They were shocked. Importance of study design. I'm going to see if I might hit this one a little bit somewhere else, actually. I'll go back to it and talk about it for a second. So this is, we talked about, the different kinds of study design that can be used. You don't necessarily have to have a randomized controlled trial. You don't necessarily have to use the endpoints that the payers may have identified previously in order to prove your point. Sometimes you can't. You know, this was a case where we had a client who, you know, they have technology that's marketed in Europe, so they do have some revenue coming in, but they're not available in the US yet. But they know that they need a lot more data to convince the US payers. And what the payers were telling them is it has to be an RCT, you have to compare your technology to the standard of care, it has to be, you know, a two-year study, it has to be this particular endpoint. And what they determined with a lot of previous work that they had done was that in order to conduct the study that the payers were telling them that they wanted, they would need 300 patients per arm in the study, which for any of you who have ever, you know, conducted clinical research, that's really a lot of patients, and it's really expensive. And there was just no way that they could conduct that study. And so what we were able to do for them is to say, okay, this is going back to kind of the payer panel approach that we talked about a second ago. Let's look at this in a different way. Let's look at what this technology is doing that's different from what the standard of care does. Let's look at, you know, more comprehensive implications on patient outcomes. So we need to know, you know, longevity of the treatment. You know, are you going to need repeat procedures? That's important. That was the number one from the payers. But also from a patient perspective, what about, you know, length of stay in the hospital? What about, you know, return to work for kind of an employer-based perspective? What about some of these other endpoints? Is there a composite endpoint that we could design, that we could conduct still a comparative study that would be small, in order to prove statistically significant differences? And so, you know, in really taking a more holistic approach, reaching out to a payer panel, seeing what was meaningful to them, we were able to design a much smaller study with a non-traditional endpoint that got them where they needed to go. So sometimes it needs just some out-of-the-box thinking and, you know, partnership with the payers. And again, you know, I typically say this much earlier on in my presentation, but I have a lot of clients who come and they want to regard the payer as the enemy because the payer has the big no stamp. So you want to regard the payer as the enemy. How are we going to get past the payer? How are we going to trick the payer? How are we going to, or it can be the facility. How are we going to, you know, they're the enemy. Don't think about them as the enemy because that's not going to help you. You know, maybe somewhere back in your brain you can still think about them that way, but they're your customer. You got to think about them as your customer. So they're telling you what they want. You need to give it to them, or you need to work with them and help figure out collectively what you can do that satisfies.
So many different pairs. How do you get them all on the same page? I mean, do you have different conversations? Like one person might say real-world evidence registry is great. Other person might say RCT. Other person might say, how do you get them on the same page?
You know, if you bring them all together, they'll get on the same page more rapidly than if you talk to them separately. It's just sort of human nature. You know, so if you have a panel where you bring 5 of them together, and maybe it's not in person, but maybe it's just like a web panel or something, and they have conversations, they'll get to the same page more quickly than if you just have separate conversations with them. But you also may find that there's one outlier that's just like, it has to be an RCT, and it has to be this endpoint, and I don't care, no matter what. Okay, well, you know what? You might not get favorable coverage for them for a while, but you'll find some that will be willing to accept. And so you just kind of start to build, you know, from where you have the least resistance, like with anything.
Do you find that payers would want an endpoint that focuses towards reducing costs versus reducing morbidity, or which one would they?
They're usually linked.
They should, yeah.
Repeat the question.
Yes. So the question is, are the payers more interested in reducing cost or in reducing morbidity? And they're usually linked, but on the surface, they will tell you they're reducing morbidity. They will very often not tell you that they're interested in cost at all. All of their decisions, they say, are based on medical necessity. But implicit in their assessment of medical necessity is cost. So know that, because they won't admit to it out loud. They'll tell you they don't consider it, but they do. So they'll tell you it's about morbidity, but it will also be about the cost. And they're usually linked. So if you're reducing long-term morbidity, then you're reducing long-term other treatments, which ultimately is going to reduce their cost. But you have to sort of link it back to that and show them the cost effectiveness, and they are looking at it. They'll just tell you, oh, no, we don't need to see that. Yeah, whatever. Here it is. Because you know they're going to look at it. Yes, John.
if you introduce a product that is at parity with what they presently have, this may have been asked, I apologize, but you can show, I won't say dramatic savings, I'm going to kind of ask you for a percent, but at what point are they willing to say, we're going to switch vendors and we're willing to retrain our clinical staff to use your product instead of what we're presently using, even though outcomes are the same, but you could save us X percent. At what X percent is it worth trying this game versus, you know, it's a Me Too product under development?
Yeah, I mean, I think if you're showing something significant, I mean, I would say if it was 20%, you're golden. You know, if you can go in with that argument, you know, the question is, are you sure you can prove parity to them early on? That's another question. Because one of the things that, you know, I've learned over the years is there was a long time when surgeon preference ruled. You know, whatever the surgeon wanted, the surgeon got. The facility would pay for it. And then the dial swung all the way over to whatever the lowest cost supply was, is what won. This is what I call the shower effect. So you get into the shower and it's way too hot. And so what do? You're like, oh my God, it's too hot. And so, well, kind of like what happened with the room today. It was really too cold, and then it got really too hot very quickly. So you turn the dial all the way back until it's too cold. Oh, it's too cold. And then you turn it all the way. And after a while, you start to adjust it like this, so you're, you know, somewhere. That's what's happened with facilities. So it went from, it was all surgeon preference, and then it was all the price. And then they're like, well, wait a minute. It might have been a low-cost supply, but somehow that low-cost supply was costing us money later. We don't really know how. But it was, because our costs haven't gone down the way we thought, and so now they look at both. So the early question is, are you sure you can prove parity? You know, can you prove equivalence? So that's part of the question. But if you really can, and you can say, look, we'll save you 20%, even though it means more training, even though it means more, you know, restocking our supplies, all of that, then you've got a pretty good argument. If it's somewhere, you know, below that, they'll still talk to you, but you have to figure out kind of how it fits.
My name's Nick Green. The idea you had earlier on of having pairs on a panel, very cool. We've always approached it one-on-one. So I'm interested in two things from a practical point of view. One is, how do you get all the pairs together on a panel? And number two, I might be slightly paranoid, but if one of them raises an objection, because objections can sometimes be contagious. How do you manage that? So how do you get them together, especially sometimes when there's like benefit to each other? And then secondly, how do you handle the actual...
That's a great question. It's a great question. And the answer to that is, don't bring them together until you know what they're going to say. So you do a little bit of both. You talk to them individually, you kind of get a feel for where they're going and what they're thinking and all that stuff before you bring them together. So you kind of do both ways, because the peer pressure can go both ways. You have somebody who's really positive, oh, well, I'd accept this, well, then the others will you know, tend to glom onto that and be more positive, but you're right. Yeah, objection can be contagious, and so you can balance that a little bit if you start off with some individual conversations.
Have you doing 8 case studies?
I do, and we're not going to get through all of them. No, but it's okay. We've done lots of questions and...
Show of hands, who wants a copy of this presentation?
Okay, well good.
So,
I can send it out.
We can figure out a way to do that. A surefire way is throw business cards at her at the end. You need help picking them up.
Okay. So let's be like roses at the ice skating rink or something. Something like that. Okay, so we are not going to get through all the case studies, and that's fine. I'm happy to talk to anybody afterwards. I will obviously share the presentation as well. But this is one that I think is important, trouble with diagnostics, and we talked about that with the myths. But this is a really good case study. So again, this was an example from years and years ago. At the time, it was a startup med device firm. They had this, you know, I'll say virtual biopsy technology that they were 100% convinced. The story to tell was that this would eliminate the need for physical biopsies during esophageal procedures. First of all, we said that's a really bad idea to say out loud, because pathologists will really not like that so much. And you really don't want to have the Pathologist Association banded together going after your technology, which is what they would do. So that's number one. And secondly, payers are not going to look at it like that. Again, payers are going to look at it, and especially in the US, I mean, as you know, we're a very litigious society. So here's a physician who's looking at this and saying, okay, I'm pretty sure this is not cancer, but I need to cover myself, and I'm going to take a biopsy anyway, just to be sure. So they want to use the new technology, but they're like, but if I don't take the biopsy and then this patient turns out they do have cancer, I'm in trouble. So they use the technology, they think it's cool, they think it's wonderful, they think it tells them stuff, but they still take the biopsy. And so that's exactly how the payer views it. So we told this client, you don't want to do that. It's not going to be true. The payers are not going to like it. And they didn't listen to us, and they went out and they had a lot of trouble initially. And they came back to us several years later saying, okay, our new strategy is that we enable unlimited biopsies. So that you still are going to take your few physical targeted biopsies, but we're also letting you basically take unlimited virtual biopsies. And so we're detecting more cancers. And now that's our story. Our story is not reducing biopsies, our story is detecting more cancers. And so it was a complete shift in their strategy. But what we ended up doing with them is, really developing, both payer-focused tools to help them understand why they should cover, what was a new CPT code, that was a new technology, helping them to see how using the technology would identify more cancer earlier, which, to the question from before, is important. You identify it earlier, there's less aggressive treatments, it can tend to cost you less money to treat a cancer that you identify earlier than later, and obviously the patients have better outcomes. But at the same time, also looked at developed facility-focused tools that let the facility see how, even in cases where they weren't being reimbursed, how it could be beneficial to them. So it became kind of a multifaceted approach. But it's just, really pointing out how you have to think about it from different perspectives. Think about it from the payer's perspective. Think about it from the payer, understanding that they've got physicians out there who are going to behave in a certain way, and that your technology is not going to immediately change their behavior. And you have to manage that. Okay. So this is another one that addresses that. Your market. You want your market to be as large as it can possibly be. Myth. So again, you want your investors to think that early on, that your long-term potential is that your technology, like in this case, might be used in every single asthma patient. That's not the story you want to tell your payer. So even if, in this case, it was a medical device firm, they had an asthma management diagnostic tool, very inexpensive, like $20 per use, point of care, and do it right in the office. They're like, payers are going to love this, costs a lot less than spirometry. They're going to think it's great, it's going to save them money. And we said, no, they're not going to look at it like that. They're going to look at it as physicians are going to love this. They're going to want to use it every time an asthma patient walks into their office. When maybe they would only use spirometry once a year, or once to diagnose a patient with asthma that they strongly suspected had asthma. The physicians go, oh, this is easy and it's inexpensive, and I'm going to use it every time these patients walk into my office. And it's not proven that it's going to really benefit the patients. And so instead of seeing $20 versus $80, they saw $20 times 8 million patients, in their population used 4, 5, 6 times a year. And it's not proven that it's going to do anything to improve the patient management. So yeah, it seems like not expensive. To the payer, it's a whole different perspective. They see potential for widespread misuse, that $20 times 8 million times 4, that's a lot of money, versus the way the manufacturer was thinking about it. So what we suggested that they do, and again, they didn't listen to us at first, which happens a lot, and they kind of went out, and it, they really just got negative coverage decisions. It just wasn't being, yes?
Beth, does this harken back to the days of physicians and physician practices utilizing, per se, a CPT code for making money in their practice?
Yes, absolutely. And this is where, fee-for-service physician perspective versus fee-for-service payer perspective are totally at odds.
Right.
And it makes for a very difficult argument, because you want to tell the physician how it benefits them to use your technology. But as you're doing that, you're telling the payer why it hurts them, because they're going to have to spend more. That's where the value-based argument becomes easier, because it's the same story for both.
And this can also be targeted to the IDNs, correct?
Yes.
It's a whole solution.
Mm-hmm. Absolutely, absolutely. So, but that's a great point, because yeah, you'll have a physician who again is like, I love this, and even if they're not just greedily thinking I can make a lot of money from it, they're thinking this is something I can do right in my office while my patient's here, and I think it'll help them. And so, you know, they're making money off of it, yes, but they can also think they're helping their patient. But from the payer perspective, the payer's like, yeah, but are you using it appropriately, or are you overusing it? And so that's sort of the situation that was happening here. So what we recommended to them when they started meeting these objections with the payers is to say, look, most asthma patients don't cost the payers a lot of money. Most asthma patients are pretty mild, and if they get on inhaled corticosteroids, they're managed pretty well, and they don't end up in the emergency room, and they don't have, you know, hospitalizations. But there's a small group, like, you know, between 5 and 15%, that are difficult to treat, they're uncontrolled no matter what they try to do with them. Those patients cost the payers a lot of money. So you ought to focus on that group where the payer's already bleeding, where the payer knows that they're hurting, they're losing money, and show how your technology can help reduce costs in that patient population. So you've done two things. One is you've made that target population much smaller, which is much less scary to the payer, and you're helping them address a pain point they already have with a low-cost technology. And so once they adopted that approach, we were successful in, you know, getting some pilot studies with different state Medicaid programs and demonstrating in that patient population, started to get favorable coverage in that smaller group. Then you start to get broader coverage, so that, you know, story starts to build.
How do payers view a scenario where there's an increase in cost or a net increase in overall quality of life? So I know in this scenario you have a net increase in cost, but then you're also doing unnecessary application.
Mm-hmm.
But if it is absolute net increase in quality of life and the cost of absolute increase, how do they view that?
That's when you're looking at that cost effectiveness ratio, where you have to look at that incremental cost effectiveness ratio. They want to know how much more to get one additional unit of benefit. And that's related to that 50,000 per quality adjusted life year. That's kind of the typical metric that you see. That's, people now say that they're evaluating a little higher, like 75,000 per quality adjusted life year. It's sort of bogus, all of it. But 50,000 is kind of the threshold that they're used to. So in that scenario, you know you're increasing cost, but you know you're improving quality of life. That's the metric that you want to measure, because that's what they're looking for.
So it's not a zero-sum game. There's costs can
costs can go up if you're improving outcome.
Yeah, as pharmacies move more into being providers, and as the example, CVS buying Aetna, how does that blur the lines, and how's the long-term effect? Do you see that where the provider is now the payer as well? And do you think that's going to be a significant change in the industry going forward?
Yeah, I think it's all changing right now. And we don't know exactly how that's going to shake out, but I think we're going to see the shift that it all becomes more of the value-based perspective in that scenario, where the provider is the payer. You know, it all becomes one story versus these competing stories, like the scenario we talked about, where we have the provider story that wants to drive utilization and the payer story that wants to limit utilization. This becomes more of a one story overall, trying to contain costs, and everybody benefits when you do that, and everybody suffers when you don't do that. I think it's a gradual shift, but it is shifting that way.
What do you think the time scale is on that?
You know, I don't know. You know, we're never going to change to entirely value-based. I don't think. You know, I hate to say never, but it's going to be very slow, because our system is just so complicated. Unless we move to a national payer, you know, one national payer, which I don't see happening ever, because we just don't like that in the U.S. There's too many political factions. There's too much power with these private payer groups. I just don't think that's going to happen. It's so complicated how it all fits together. I don't think we're going to move to entirely value-based for a very long time. But I would say we're going to say, you know, a shift where there will be some value-based component over the next 10 years, where it will be mostly value-based, but still some of this other element. But honestly, I don't know. Some of it depends on who's in office. Depends on, you know, all of those things.
Are the med tech companies also you know, shifting their focus to try to communicate a value-based argument, or
they're sort of struggling with it still, they're struggling with it still, with that shift.
Okay.
I think so many of the med tech companies are so invested in this fee for service, and they're so focused on the codes because they've had to be focused on the codes for so long, and you still need the codes. I mean, you still have to understand that they're having a hard time shifting unless it's clear that that's where their value proposition lives, and that's the only place that it lives, and then they're willing to adopt it. But the ones that can create a good fee-for-service story, they tend to want to live there, and you kind of have to push them to think about it.
And you are pushing your clients.
Yes, I'm telling all of my clients, you know, mostly all of my clients, sort of depends on the technology, that you need both arguments. You need to be able to tell your story this way, and you need to be able to tell your story this way as well. Okay, this goes back to the simpler is better. When you have simple, tell a simple story. I have a lot of clients that will come to me and say, because they've heard this terminology, I want you to build me a Markov model to demonstrate the cost effectiveness of my technology. And sometimes I'll say, why? And they'll say, because we saw this great publication, it was a Markov model that showed 10-year cost effectiveness and blah, blah, blah. I'm like, yeah, but your story, you could tell it like this, and it's easy. And they're like, well, but isn't that too simple? No, if you have a simple story, tell a simple story. So here's a perfect example. Client, startup med device, they had this really, really cool small bowel feeding tube. Cost a lot more than what the hospitals typically use, but it could be placed much easier. It didn't require x-ray guidance. It didn't require, you know, multiple tries where you had to throw out the technology because it didn't get placed right the first time. You got to throw that one out and start again. They had data that showed that. I mean, they had data that showed their technology could be placed correctly the first time, 98% of the time, versus, and now I'm just making the number up, versus what existed that could only be placed correctly 60% of the time. So you had to use more feeding tubes if it wasn't placed correctly, and you had to do it under x-ray guidance. They had the data, but they weren't telling the story. So the story was just line it up. Here you use one feeding tube, no x-ray guidance, it takes this long, it takes this much resource. Here you end up using 4 feeding tubes, and you have to bring the x-ray machine down to the bedside, you have to use these resources, line it up side by side, straightforward. You end up saving money. Your tube costs more, but you easily show that you save money. That's as easy as it gets. Just show that. Don't create this complicated thing because you think that you need to. Just tell your story. Okay, this one also relates to, you know, a question from earlier about using ex-US data. So maximizing the data that you already have, figuring out what to do with it. So this sort of encompasses, you know, maybe it's data coming from Europe, maybe it's data that's coming from a whole bunch of investigator-initiated studies they've all been published, but they had different patient populations, they had different time frames over which they measured effectiveness. They're not easily combined, but there's been no one huge definitive study. You know, figure out how to maximize the data that you have. And so in this case, it was a company, they had this innovative radiation therapy for use in breast cancer. It had been used for a long time in Europe in particular, but also in the US, but they didn't have any one large kind of definitive study comparing their approach to traditional external beam radiation therapy in terms of recurrence rates in breast cancer. But there were all these individual studies that had been conducted. So we said, well, let's see what we can do with that. So we, you know, did a pretty extensive meta-analysis that, you know, combined the results from all of these studies and enabled them to demonstrate, you know, their 5-year recurrence rate, which was really what the physicians wanted to see. So, you know, it was not conducting a new study, pretty inexpensive approach to really maximizing their data and giving them something meaningful. I think this is case study 8. We have 4 minutes left. We're going to make it, believe it or not. Database analysis. Okay, so again, you know, this is just pointing out kind of the different scenarios that you'll encounter. So this was a client who had a surgical sealant that could be used in sleeve gastrectomy procedures. And they were finding, so this was a sell to the facility as to why they would want to use the surgical sealant. This was not something that a payer was going to reimburse separately. This was something a facility argument. What the facilities were saying is, look, why are we going to pay $150 or whatever it was extra per procedure to prevent an event that happens only 2% of the time? And of course, you'll also find this phenomenon is true. When you go and talk to hospitals about preventing complications, they don't have those complications. Well, our surgeons, we don't have leaks. Those don't happen here. You know, you hear that a lot. Okay, well, on average, yes, it might happen 10%, but not here. So that happens. I'm sure you've heard this. So they were getting this pushback. They're saying, well, I don't know why we would spend prophylactically $150 on every single case to prevent something that happens in only 2% of the cases. So we had to create that reason for them to care. And so really what we did is said, well, let's figure out, even if it only happens 2% of the time, or at your facility, 0.2% of the time, you know, or whatever really low rate, how much does this cost you when it does happen? Because if it's catastrophic, even if it only happens 2% of the time, it can be worth it to spend $150 per case. And so that's really exactly what we did, is we used administrative claims data to figure out, first of all, how often does this really happen? And then when it does happen, how expensive is it? And in this particular case, really expensive. Because if you have a leak, if it's identified immediately, which is usually not, it wouldn't be too horrible. But it would still require additional surgical procedure, going back in and sealing it up. If it's not identified early and it becomes septic, that's catastrophic. So, you know, the patient can die, or it can cost just a whole lot of money to treat. It can really be a very catastrophic event. So that's what we identified, is it didn't happen all that often, like 3 or 4% occurrence, but when it did happen, it cost them more than enough money to justify preventing it with a surgical seal. Okay? Wow, that was amazing with the questions and everything. We ended pretty much right on time. Again, I am very happy to send the presentation out to anybody and everybody who would like to see it. If you throw the business cards up, I will collect them. Be very happy. There's my contact information. You can reach out to me via email as well, or come talk to me afterwards. Thank you very much. I really appreciate it.